Well, hello and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of 3 co-hosts who present this weekly series on behalf of the Canadian Premature Babies Foundation. I am a career broadcast journalist and mom to 3 NICU grads, including preemie twins who were born at 32 weeks and are now 12 years old. I live and work in Mi'kma'ki, outside of Moncton, New Brunswick. Well, Canadian Premature Babies Foundation is the presenter of Preemie Chats, and you can find more information about our organization on our website. You can see it there on your screen, canadianpreemies.org. The foundation is a parent-led charity that helps families during and after their NICU time through support, education, and advocacy. I hope that you will take some time and visit the website there, canadianpreemies.org. You will find all kinds of resources available on the site, our RSV handbook, which is available now in multiple languages, our podcast, our previous preemie episodes, and most importantly, you're going to find a community of parents and professionals who are working together to help our children thrive. I would love for you to engage in the comments today. Let us know where you're watching from and what brings you to Preemie Chats. Whether you are a parent or a grown preemie, please feel free to share your questions in the comments today and let us know where you're watching from. Well, today's Preemie Chats is going to focus on a topic that impacts many NICU families, jaundice. And jaundice is a buildup of pigment or bilirubin in the baby's blood. It can lead to skin or eyes having a bit of a yellowish color. And it's actually fairly common among babies, especially those born before 37 weeks. And we're going to find out all about what it is, what's happening, and to talk about jaundice and what the Canadian Paediatric Society's latest guidelines are for managing in infants, I'm going to be joined today by Dr. Eugene Ng. He's a neonatologist at Sunnybrook Health Sciences Centre. He's an associate professor of pediatrics at the University of Toronto, and he's a member of the Canadian Paediatric Society's Board of Directors. Welcome to Preemie Chats.
Thank you, Jenna, and thank you for the opportunity to present at the Preemie Chats once again. And thanks for the introduction. I am a neonatologist from Toronto. And the reason why we're doing this topic today is because I'm also the author of the Canadian Paediatric Society position statement on jaundice that was just released in March of 2025. And I'm also now working on a similar statement for the CPS on the preterm jaundice babies. So I have a small presentation that I would just sort of want to give a foundational principles about jaundice and jaundice management. And then we'll more excitingly go over some of your questions when we're finished. So I would just like to sort of reiterate what Jana has already said to you, that jaundice is extremely common. And even though the current statements from the CPS, it focuses on babies who were born at term or late preterm or close to term. In fact, the idea about neonatal jaundice is almost universal in preterm babies. And so, almost every single premature baby will go through some levels of jaundice. And so this talk is also relevant for those of you who has babies who are born preterm. So to understand jaundice a little bit, again, it is the yellow coloring of the baby's skin and the eye because of a buildup of a substance called bilirubin. And it is very common, and for term and preterm babies, the majority of the babies could be affected by jaundice at a different level, and mostly during the first week. And I would say for premature babies, could be 1 to 2 weeks or even more. So what caused this? Bilirubin is a substance that is formed from the breakdown, which is a normal process of our red blood cells. And red blood cells is what's circulating oxygen to the rest of our body. Is essential to survival. And so but they do have a shelf life, and red blood cells will break down naturally, and sometimes there are more reasons for it, and we'll talk about it afterwards. And for babies who are born a little bit premature, the liver, which is primarily responsible for processing this substance, is also premature, and so they could have sort of a problem with handling the load of bilirubin that is normally broken down in your body. And so therefore the excess of it, or when your liver is not able to handle the metabolism of bilirubin, that's where you have an excess amount of this circulating bilirubin in your bloodstream. And then when they're excessive, they will start to deposit in the skin and the whites of the eyes. And obviously, if the level is very high, what we don't want to see would be the jaundice level or the bilirubin start depositing in the brain that causes injury. And so that's really the whole objective of managing jaundice, is to prevent a high level of jaundice that the bilirubin will go into the brain and cause injury. And typically it occurs in 2 or 3 days after birth. And for term babies, it peaks around 72 hours, and in preterm babies a little bit later. And again, the resolution of it typically within 2 weeks, and in some of the preemie babies could actually be up to almost a month. And sometimes you see that the rebound in the NICU. Sometimes you see that some babies will be on treatment for a while, we stop it, and then we'll have to restart it again. And that's not very uncommon at all. Okay. Now, so how do we deal with this? And I think first we have to detect that there is a level of bilirubin that require treatment, because not all, so bilirubin or jaundice really just refers to the yellow color discoloration on the baby's skin, and really it's just a crude measurement of the severity of jaundice. And obviously the way to do it for real is to do a blood sampling, just to measure the exact level of bilirubin in the body, just so you know, because looking at the skin level is very inaccurate to determine just how high the level is. And so, on the left side, you can see that this is one of the graphs that we have created for the guidelines. And there is, I think to manage jaundice effectively, you need to have some standardized process. And it's because you could sort of say, well, the baby looks a little bit yellow, so we probably should put on some treatment. But you don't know whether this is very high or that you have to go beyond a certain treatment, such as more than just phototherapy. Maybe you have to think about giving more fluids, etc. So it is the gold standard of the test is do a serum test or blood test to measure the serum bilirubin level, and we sort of call it, some people call it the MBR or mean bilirubin, or the TSB or total serum bilirubin. There are many different conventions, but basically we're just measuring the bilirubin level in the body, just to give you an idea of how jaundiced the baby is. And so if you look at the graph also, it's also very interesting to find that there's a steeper increase in the first 3 days, and then it kind of plateaus off. And this is what bilirubin tends to behave. And so that's why the first couple of days when the bilirubin start to be a little bit more sort of aggressive is the time that you need to pay attention to. And those are the time that you will notice that doctors will order more of the bilirubin testing for babies, just to be sure, because that's the time when you see the highest levels. So as I said to you before, premature babies are more vulnerable because their organ system, especially the liver, is more immature. And also, the level that is high enough for it to sort of breach the level to go into the brain and cause injury is a little bit lower for premature babies, because the barrier for the bilirubin to reach the brain is also a little bit more immature. So obviously, we don't really have a clear guideline right now for preterm babies. Everybody's using guideline that we've been using for many, many years. But if you sort of compare the level of treatment for premature babies versus term babies, the premature babies tend to be treated when the level is a little bit lower for those kind of reasons. And it is not enough to just say, like we measure a level and then we start treatment, because, we also have to know when to stop. And to do that, you're going to have to continue monitoring the babies with doing more blood tests at a certain intervals to make sure that it's going down nicely with treatment. And then obviously, if it doesn't go down properly, then more treatment may be required. And often, and although for premature baby, that tend not to be the reason for prolonged hospital stays, but for term babies who otherwise would spend 1 or 2 days in the hospital, sometimes jaundice will require them to stay in hospital a little longer. So, and I don't think we need to belabor this point again, is sort of the typical timeline of jaundice, and I've kind of already said that before. Now, this is important in this point to note that if babies become jaundice within the first 24 hours, then it is not just physiologic or just normal baby jaundice, whether it is a premature baby or a term baby. And so, I think when we see babies who are jaundice in the first 24 hours, we tend to think about some other conditions that may have caused the red blood cell to break down faster or more aggressively and created more jaundice. And those kind of cases that we call hemolysis, meaning that the blood cell breakdown is faster because there may be an antibody, or maybe there's some structural reasons. Those babies we have to pay attention to, because some of the jaundice could be very aggressive. And so if we see jaundice in the first 1 or 2 days, we tend to be a little bit more concerned. And so, as I said, jaundice, that phototherapy, which is putting a light to shine on the baby's skin to get rid of the bilirubin, is an incredibly effective method of getting rid of jaundice in babies. And so, and this has been through the test of time in decades since the discovery of phototherapy in the UK. It is still the mainstay of treatment. And so with that kind of treatment, most babies would do very, very well. I'd say that, more than 95% of babies with jaundice, term or preterm, will have no long-term side effect. And especially if we're monitoring it properly and doesn't let it go to a high level. And so the idea about management, of course, is that you need to detect it early, and you need to have a screening strategy. You need to have a monitoring strategy, which is all the guidance that we're providing in the CPS statement. And I think when we develop the premature babies guideline, it will follow similar steps. Now, so these are the most likely scenario. And I also show you a little pictorial here that kind of shows, it's a little bit sort of old learning, and I truly don't believe that there's grade of jaundice anymore. But when I was in school, people do teach about jaundice appearing in the top level of the body and then goes down, and then when it recovers, then it reverses. So it is sort of a rough indication of the severity of jaundice, but really is while I think that the pattern is right, to use that to guess the amount of jaundice in the body without doing blood tests is probably not the right idea. Now, we very occasionally, and now we are actively monitoring the cases of severe jaundice. Some of the warning signs that we'd be looking for would be neurological, meaning that it really see that jaundice is affecting the brain, and that's when we really think that could be the signs of problems. And so this is an extreme case of a baby with kernicterus, or kernicterus is really a condition where there's deposit of bilirubin in the brain, and is a condition that would severely affect development of the baby and is irreversible, at least to some degree. So I think if we start to see a little bit of neurological warning signs, then it's time to seek help. So most babies with a higher level of jaundice become more sleepy or difficult to wake and difficult to feed. But if you start to see arching of the back or stiffing up of the body or high-pitched cry, those are warning sign that really we are heading toward this way, and we don't want to. So get treatment ASAP. I also wanted to spend a minute talking about the role of feeding, because it is not just hearsay. I think this is actually real, that feeding and in some way pooping will help eliminate jaundice. It's because how we understand the metabolism of the bilirubin, it does go into the large intestine, and it could be recycled by a process called the enterohepatic circulation. But if we promote feeding and therefore promote stooling, you could actually get more bilirubin eliminated in the stool before they got recycled back. So this kind of strategy also helps. Now, in term babies, we also know that the majority of causes of babies with jaundice who require treatment are related to poor feeding or inadequate amount of feeding for this exact reasons. So I think there's a lot to say about feeding and frequent feeding, and to make sure that the baby does have proper bowel movements. Those are the things that will help prevent jaundice, or at least to help eliminate jaundice before it gets too severe. So I've already touched on some of the treatments. I think phototherapy or light treatment is still the primary treatment for jaundice. And you notice in the NICU, we tend to use blue light. It's because we know that the blue spectrum light at this certain wavelength is the wavelength that most of the bilirubin absorption under the skin is the highest. And so if you use blue spectrum light, you could actually help eliminate jaundice faster. And in this treatment, it doesn't really cause any pain or discomfort. And the only discomfort would be that we do tend to strip the baby down as opposed to bundle the baby up, because you want the maximum amount of surface area of the body to be treated with the phototherapy. And so some of the babies will become a bit more irritable in there. But phototherapy itself, the light is not hot, and the light, if we protect the eyes, is not uncomfortable. So just so you know that this is actually first of all, it's very common treatment, and it's very effective, and it doesn't cause pain or discomfort. Now, some of these and especially the middle one called exchange transfusion, is when the baby's jaundice level reached a certain threshold where phototherapy is not effective because of some sort of process. In a very, very rare occasion, we do have to do what we call a blood exchange transfusion. So essentially, we are replacing the baby's blood with a donor blood gradually, so that in the same time, the jaundice will also be eliminated at the same time. And so it is a process that has been invented in Toronto very early on in the 1950s. And that's thankfully is not used very often. But sometimes we do have to go to the extreme measure to get rid of bilirubin, again, to prevent the neurological complications of jaundice. But all babies who require phototherapy or not will also need to have supportive care when you see some level of jaundice. And one of it, as I mentioned before, is about feeding, but can also be many other things that is to support the babies in getting them to feed and feed healthily and to poop properly. And so supportive care is just as important as the phototherapy treatment. And as I mentioned to you before, I am the author of the current guideline from the Canadian Paediatric Society. It's been released in March of 2025 and is freely available to all of you. You just go to the CPS website called cps.ca, and you can download the position statement. That has taken us 7 years to develop. And so it is actually, we believe it is a good guideline for clinicians and clinicians across the world to use. And it is, we worked closely with the American Academy of Pediatrics because they have developed the guideline using their experts, and we did not deviate from their recommendations, but we do work with them to create a Canadian version that is it's just as good. It uses our unit, and I actually think that is better because we created based on our goal of making it user-friendly for all clinicians in Canada and elsewhere. And so, I think I would urge you to have a look at it. So again, just to summarize, I think what parents should be watching for is really the early signs of jaundice, because early treatment does make a difference. And obviously, especially with for term babies who do not stay in the hospital for that long, many of them will develop jaundice at the height of it when you're already at home. And so looking at the warning signs that require immediate care, including maybe being lethargic or feeding poorly or having high-pitched crying or anything else, and you've noticed the baby developing the yellowness of the skin, and you can, because you are the parent, you can see how it evolves over time. If it looks like it is aggressive, you really do need to go find a doctor to do some blood tests to see how high the level is. And then, of course, supportive care, I think mainly with regards to feeding and maintain all the other cares, and to attend follow-up appointments, it is very, very important. And so with that, I think all babies will not get the complications from neonatal jaundice, and that will be our goal. So thank you for your attention, and we should open the floor for hopefully lots of questions.
Yes, thank you so much for that. That was really interesting. There were a few things that really kind of stood out to me that I'm going to ask you some questions before we see if there's any in the comments. Although first I will mention, I did put in the comments a link to the guidelines that you mentioned there on your website for someone looking for them quickly. They'll be able to find it in the comments now. I'm wondering, I guess, two kind of things. We were talking about the potential impacts of jaundice, which you were very clear to say that this would refer to a very small group of infants who may, have long-term impacts from something happening. Can you share a little bit about what the impact on the brain could be if all of these preventative measures, aren't working?
For sure. And now, I mean, this is most relevant in the term babies because, like I only say that because most premature babies are cared for in the NICUs, and monitoring for jaundice is almost a ubiquitous protocol. And so if we monitor closely, really most babies will not get to a level that is dangerous enough for us to worry about. So what I'm referring to is there's many different terms for it, but I think just to be clean, the term is kernicterus. And kernicterus really refers to the deposit of bilirubin particle in the brain, especially in the brainstem area. And so, and it's the old studies that look actually at autopsy studies to look at the yellow staining of these substances of the brain. And so we kind of correlate that, and now there are many other sophisticated ways of looking at it. And so it directly relates to the level of jaundice. And so it is important to pay attention to babies who had a higher level of jaundice. The incidence, thankfully, is very low, but it's not zero. And the reason for that is there are some conditions that would predispose the baby to have more severe jaundice. So let's just say most of them are related to a faster breakdown of red blood cells. So if you have an antibody, let's just say if there is an incompatibility of blood group between mom and baby, or that you have some inherited conditions like G6PD, which is a metabolic disease that affects the red blood cells, and many other things that would make a red blood cell more vulnerable to be destroyed or to be broken down. And so you will have a very high source of bilirubin that even with phototherapy, it may not be able to get rid of it quickly. And so, when you have these conditions, you could have deposit of bilirubin into the brainstem. And so there are long-term effects because, as I show you a little bit about some of the neurological presentation that is really in the immediate period, or when your level is really that high, but if it's not being treated properly, many of these babies will be at risk of more neurodevelopmental problems. And so we do see a variety of motor and developmental disability as a result of kernicterus. And the classic of kernicterus is a motor handicap that we call choreoathetosis, and that's really is just about a movement disorder. But obviously, because it affects the brain and it could affect long term, there could be a variety of developmental problems that you see. And so this is again, is something that we really try to protocolize the management of babies from the beginning, because it is completely avoidable. And and I guess the way to find out also, and especially with implementation of new guideline, is to monitor for the incidence of that in a country like Canada. So we do have that mechanism. There's the Canadian Paediatric Surveillance System has agreed to open up a survey for clinicians to put in cases of jaundice level over 425, which is really high. And so in the next few years, when we look at the report, we should be able to see whether what the incidence of that neurological complication may be. They are really rare, but I would like to see it to be completely eliminated. But as long as it doesn't, as long as the incident doesn't increase as a result of a certain practice, then I think we're okay. So we have to keep an eye on that.
Thank you for that. I'm also wondering too, because it's something that's very much connected to liver function, are there any long-term implications, that we know of, in adults with their liver function because they were jaundiced as infants? Is that something that we've been able to look at all?
No, I mean, so jaundice doesn't really affect the liver, but if the liver is immature, no. So one, if the liver is immature, that it could have problem processing the bilirubin, and it may cause jaundice, but then the liver would eventually mature. Then there are a whole separate category of liver problems that would lead to different kind of jaundice. And so this is completely out of the scope of our discussion. And in those, even as an adult, you will have problem with jaundice. And so that's a whole different kind of disease category. And this is not covered by these current guidelines. But to answer your question, simply the level of jaundice in babies does not actually cause liver problem itself.
I think it's always good to hear that it's not causing other things and not having these long-term implications, because I know it's, as someone who had an infant under those lights and watched other people come into the NICU to see their babies under them, it looks a little scary sometimes if you don't understand what's happening.
Absolutely.
But like you said, it's so non-invasive and so helpful and such a wonderful solution that I think it's so important that we talk more and more about the fact that it's a really good thing and not a scary thing, even
Mhm.
when you have your tiny little infant under those big glowing lights.
Exactly. Yeah. So, I mean, it is really the invention of phototherapy is based on the observation of premature babies out in the yard in the sunlight, and that's a long time ago, and that's how they discovered the phototherapy treatment. But we would not go as far as to recommend that people do that, only because of the issue of the ultraviolet radiation on newborn baby skin. So just use the phototherapy light that is medical grade and fully calibrated, and is safe. And so it's not quite the same as a tanning booth. Some people think of it as a tanning booth, and so please don't think of it that way, because we actually do not use ultraviolet radiation, because we know that damages the skin.
I don't see any other questions coming up in the comments. We've had a few people letting us know they're watching along. I'm wondering, just before we kind of wrap things up, if you could talk a little bit about, again, the importance of having these guidelines and having things that we're going to measure, and really kind of looking forward to what is it that you're hoping will come next in this process of, paying attention and studying jaundice in infants in Canada.
I mean, it is very interesting that just thinking about how these guidelines are developed, and most of it is not really, it cannot really be informed by big clinical trials, because we cannot subject babies to jaundice and not treat them. And so obviously there's a lot of it based on expert opinions, which is fine, because for decades jaundice guidelines are based on expert opinions. And it's been through the test of time to know that they work. And so, I think the whole idea about is not exactly evidence-based practice. We do it as much as we can. But you can see that the development of guidelines are really based on people who have been through it and know and studied millions of babies to inform us. And so, I think, and management of jaundice is one area that I believe that standardization of practice makes a big difference, because we all have to talk the same language. And so, babies go through different phases. They could be in a hospital, they could have gone home and be seen by a doctor again, could be readmitted to a hospital. If everybody uses somewhat of a different standard, then it is very confusing. And ultimately, we want to, and the guideline, when it's implemented, tend to have studies afterwards to see if it is effective. And so the last jaundice guideline we have is in 2007, and many studies have looked at it, and it stood the test of time, and it works. And so, I've also sort of I wanted people to feel comfortable knowing that we have done comparison study with the new guidelines, and they're not huge deviation from the previous one. So we're not going to cause more problem. I truly don't believe so, but obviously we have to monitor for it. So, again, the whole idea about protocolizing things is that, every baby who comes through our door will be treated the same way. Doesn't matter where you are, where do you live, as long as, the people are using the guideline, and the guidelines are really reachable to every community with different kind of setting, and we pay attention to the potential for all the lower resource settings in the rest of our country to make sure that we're not recommending things that are too esoteric for people to follow. It is really bread and butter. We actually hope that everyone can use the guideline and use it effectively, so that we are managing all babies with jaundice exactly the same. So that's the hope. And so for premature babies, there's even less evidence for us to inform how do we do. So I've just done a survey, and I'm about to look at the results of all Canadian neonatal ICUs to see how babies with jaundice in the NICU are being managed. And of course, there are also a variety of different sources of material, and hopefully we will be able to produce a Canadian guideline for everyone to use in the coming 1 or 2 years.
Fantastic. Well, I'm sure that we'll have you back for Preemie Chats to update us on that when you have all that information gathered and you've had a chance to go through it.
Be happy to.
Thank you so much. Thank you so much for taking the time to be with me today.
Okay, thank you, Jenna, and thanks everyone for listening today.
Yes, thank you all for watching and joining us today. A reminder, my guest today was Dr. Eugene Ng. He's a neonatologist at Sunnybrook Health Sciences Centre, and there is a link in the comments where you're watching if you want to look more into those guidelines. You can also, of course, find resources on our website, canadianpreemies.org. You'll find a replay of this discussion if you want to share it with someone that you think would be interested in information, and take some time to go through the website and find the other resources that are there as well, including we have an RSV fact sheet that's now available in 19 languages. And of course, this is the season where you want to be very up on what's happening with that. Again, I want to thank you all for taking the time to be with me today, and to remind you that Preemie Chats happens here every Friday afternoon at 1 p.m. Eastern Time, and it's thanks to individual donations and our sponsors that make this happen. So thank you for supporting this charitable organization and its work to empower families every step of their journey. I hope you have a wonderful weekend, and until next week, take care.